Good morning. Let me introduce you my PhD topic titled Iron Deficiency Anemia During Pregnancy, Effects on the Offspring. I am Isabel Amorim. I am a dietitian and currently a PhD student in the Center for Translational Medicine. My supervisor is Nando Raj, and my scientific methodology supervisor is Nanette Sabo, and my statistical analyst is Peter Matrai. I have a vision that pregnancy can have better outcomes through early detection of anemia and implementation of nutritional interventions. And my mission is to raise awareness among pregnant patients regarding the effects of anemia during pregnancy. I have currently 2 projects, which are meta-analysis. The first one I'm going to present now is investigating the association of iron deficiency anemia on pregnancy outcomes. A systematic review and meta-analysis. Iron deficiency is the most widespread nutritional deficiency worldwide, and iron deficiency anemia specifically is accounting for more than 75% of all anemias during pregnancy. It is known as to be a risk factor for pregnancy outcomes, and these pregnancy outcomes, they may lead to morbidity and higher mortality of both mothers and offspring. Anemia in pregnancy is characterized by a hemoglobin lower than 11 grams per deciliter in the first and third trimesters and lower than 10.5 in the second one. And it can also be divided into 3 degrees of severity: mild, moderate, and severe anemia. And the pregnancy outcomes that we have interest in, I'm going to name a few, is preterm birth, which is characterized by any live birth less than 37 weeks of gestation, with a prevalence of 10% worldwide. Small for gestational age, which is characterized by newborns with a birth weight less than the 10th percentile for gestational age. And intrauterine growth restriction, which is impoverished fetal growth, and it has many causes: fetal, maternal, or placental, and it has a prevalence of 8 to 10% worldwide. Our aim, therefore, is to identify the interrelations between iron deficiency anemia and the pregnancy outcomes of interest. Our clinical question is, does anemia increase the frequency of adverse pregnancy outcomes? So we have in the population pregnant patients in all trimesters. It can also be 3 months before pregnancy. Anemia and outcomes of preterm birth, spontaneous abortions, intrauterine growth restriction, small for gestational age, and stillbirth. We hypothesize that anemic pregnant patients, they have a higher risk of having these adverse pregnancy outcomes. Our clinical and research implications are to decrease the adverse pregnancy outcomes by identifying patients at risk and implementing the correct interventions. We conducted a systematic search into 3 databases, Medline and Bayes and Cochrane, and our search key was divided into 3 main domains containing population, condition, and the pregnancy outcomes of interest. This search yielded more than 20,000 citations that we narrowed down to 200 full text to be included in the systematic review and 96 articles to be included in the meta-analysis. I'm going to present some of the results because we have 20 plots, so I'm going to present 6. And the results for preterm birth, they are very much likely what we have in literature so far. So we have that anemia is indeed associated with the preterm birth delivery, accounting for 62% a higher risk. 62% higher risk, and all of these were significant. And we can see that the risk is also increasing according to the degree of severity. So the women with severe anemia, they have a 4 times higher risk of having preterm birth when compared to the ones with mild anemia. Small for gestational age also showed significant results, however, only for severe anemia. We have also almost 3 times higher prevalence and frequency of small for gestational age in this population. And the other degrees were not significant. Stillbirth is also significant for severe anemia, so we have almost, again, 3 times higher risk. And the same occurs with intrauterine growth restriction. Severe anemia is also accounted for 3 times higher risk, but we have also significant results for anemia alone and moderate anemia. we have yielded so many results and so many pregnancy outcomes that we decided to include 3 new ones, which are neonatal mortality, perinatal mortality, and stillbirth. And neonatal mortality, just like perinatal mortality, also were significant in the severe threshold. So we have the perinatal mortality is also almost 5 times associated with anemia. Our conclusion is that anemia, it is associated with preterm birth, IUGR, and neonatal mortality, and severe anemia was associated with all outcomes of interest, also with the ones that came out after the full text selection. Our implication for practice is that detection of anemia has to be done during pregnancy, and we have to investigate the cause and intervene. The implication for research is to conduct more ICTs with intervention with different dosages of iron, because it's not well known which one would be the best for the anemic or non-anemic, and investigate anemia in different trimesters. So we have conducted the systematic review taking into account all the trimesters, but we should know which trimester possesses a higher risk. This is our manuscript status, so we are finishing the results, and it's going to be done by Monday. And the other topics, the abstract and discussion, and all the other submissions going to be done by the end of September. So we have the second topic, which is investigating the impact of iron deficiency anemia on congenital anomalies. It's also a systematic review with a meta-analysis. We have that congenital anomalies, they affect approximately 3 to 6% of all offspring worldwide, and they are divided into major and minor congenital anomalies. We have the major ones, for example, neurotube defect and congenital heart defect, and the minor ones accounting for absent nails or undescended testes, and we are very worried about the major ones, so it accounted for more than 270,000 deaths worldwide in 2010. And we have prevention strategies, for example, prevention for STIs, management of chemicals, avoidance of embryotoxic medications intake, vaccination against rubella, and fortification with micronutrients. We have already known that micronutrients intake, they can decrease the risk of neurotube defects, for example, and that folate deficiency, when supplemented, lead to better outcomes in this offspring. However, the scientific literature still lacks clearer results on the impact of iron deficiency anemia during pregnancy. Therefore, our aim is to identify the interrelations between iron deficiency anemia and the congenital anomalies, the major ones. For this, we are going to ask a clinical question of, does anemia increase the frequency of developing congenital anomalies in the offspring? We have our population of pregnant patients till the first trimester, since the congenital anomalies will be occurred by then. And the risk factor of anemia and the outcomes are going to be the congenital anomalies of interest, so congenital heart defect, for example, neurotube defect, and many others. We hypothesize that the anemic pregnant patients, they have a higher risk of having these congenital anomalies compared to the non-anemic patients. Our clinical and research implication is to decrease the frequency of major congenital anomalies by identifying the patients at risk and implementing the nutritional interventions. We have conducted the preliminary search, and it yielded almost 12,000 citations that we are going to work on these in the future. In summary, these are the current 2 topics, 2 meta-analyses, and we are going to submit to the first one in September, and the second one in February 2024. I would like to finish my presentation with a quote of the mathematician Paul Erdős. It is not enough to be at the right place at the right time. You should also have an open mind at the right time. Thank you very much.
Congratulations for your presentation. My question is related to your first topic. How did you define severe anemia? I'm curious because we could see that the odds ratios were much more higher in these groups compared to the other 3 severity groups. They were relatively close to each other in terms of odds ratios. So this would be my question, because it is important for physicians and practical healthcare workers to know what is the severe anemia.
It is a great question, because this was one of the points discussed in the project meetings. How would we define anemia? And we decided that it would be defined according to what the authors brought into their papers. So some of them defined as 9, some others 8, and many others, most of them defined according to WHO, less than 7. So we have, I haven't identified these 3 cutoff points, these 3 cutoff values. So we can also conduct a meta with only a pre-specified one, 7, and we can see what it will bring. But initially, the idea is to identify according to what the authors brought. And we are also following the definition of anemia the same way. Some defined as 12, although they were pregnant. Some others defined as 11, and others as 10. So it would be the case that we can filter this result and have a less wide prediction interval as well, because this was the heterogeneity in our studies very high. So if we do this, it's going to be better, but we are going to expect the reviewers to suggest. If they will suggest, I don't know, but we are waiting for the response once it's submitted. Yeah.
Thank you for your answer.
Congratulations.
Thank you.
Very good progress. In your first studies in the mild anemia, there were some minus values.
There was some what?
Minus values.
Minus?
Minus values for those. Can we look
Yes,
at them?
because
So what's the interpretation of that?
many studies also found mild anemia as a protective factor for some outcomes, which was pretty strange. But it can be also the case that in this one, but it's very close to 1, I would say.
There was another one where actually,
Yeah, this one, yeah. So it can be the case that it is
that's not your fault, you see. That's just...
It is not my fault, yeah. It is just how the data was reported. And mild anemia was found to be a protective factor in many studies. Some others, it did not show that much difference. So that's why we have a very either low odds ratio or lower than 1. So we do not know for sure why, but it can be also the case that the cutoff is not the ideal. So it would not be 11, for example, but a bit lower. Well, this is not for me to change, but it can be because of that as well. But just for some outcomes, not all.